Hey guys, how are you? This is Dr. Kim. So I have a great case to share with you today. So look at this periapical radiograph taken on the anterior mandible. Obviously a tooth is missing, so let me help you get oriented. What you're looking at is tooth number, let's see, 23. This is 23, and 24 is missing. And here we have 25 and 26. I want you to look at 25 and 26 carefully. First of all, it has rather large restorations in the crown and perhaps the margin, right? Looks a little suspicious. It doesn't look very good, but it's a very large restoration. I think we can all agree on that. And then let's now look at 25 first. We see this a radiolucency that appears to involve 2/3 of the root at least, and it's extending toward the mesial root, and perhaps I guess what I want to say is we see a radiolucency, but we are not quite sure the extent of this this entity. Does it involve the pulpal space? Is it simply superimposed? Is this an expansion from the pulpal space, or is it occurring something from outside going in to the tooth, right? And then as we look at the apical area, kind of difficult to tell, but it's for the most part it looks okay to me. Now when we go over to number 26, we don't have this obvious radiolucency in the root. However, if you pay close attention to the apex, there is a relatively well-defined periapical radiolucency. So this was taken back in August. And in September, our student or clinician decided to take a panoramic radiograph of this patient. And you can see the lost spatial resolution from this panoramic radiograph. It's really difficult to assess that tooth that we just saw on periapical radiograph, right? It doesn't have that distinct PDL space or lamina dura, that spatial resolution that we need. So again, I think this is a good point that panoramic radiograph doesn't provide a good spatial resolution, but it's good about giving you a large area for us to evaluate from a single radiograph. So then they completed a root canal therapy on tooth number 26. So this tooth, the lateral incisor, had 2 canals, and they did a root canal therapy. What's interesting here is that this was taken, I think, a few months after that first PA that I showed you. At least from this radiograph, it doesn't appear perhaps as radiolucent as the other one, but also now we're seeing radiolucency, or better visualizing radiolucency that's on the side of the root. So it's quite interesting, right? We want to know what's going on in 3-dimensionally. And additionally, in addition to that, we want to perhaps better visualize this area. Okay, so now I'm going to show you a COMIM CT scan of this area. First, why don't we pay close attention to our axial plane? So pay attention to this plane. So I'm going to start from the bottom of the scan, move superiorly. And as you move up the scan, we are already seeing a radiolucency centered around tooth number 26. In addition to that, we see a radiolucency that's at the lingual aspect of the tooth, possibly perforating the lingual cortical plate. It does appear to be perforated. And then we come over to 25. There's a large resorptive lesion extending into the tooth appears to be communicating with the pulpal space right here. And it has resorbed a rather significant portion of that tooth. And here as well. So why don't we start out looking at number 25. So here's number 25. Remember how it appeared on periapical radiograph? And what we saw was large radiolucency involving perhaps 2/3 of the root. But again, in terms of is it perforating, is the radiolucency enlargement of the pulpal chamber, or is this a resorption occurring from outside in? Those were difficult to answer. Those questions are difficult to answer definitively. But now with COMIM CT, we can much better visualize that area. Look at this sagittal view and see how much of the destruction and resorption that has occurred. I mean, it's extending from the apical third all the way up to the crown. And with that, lingual cortical plate is perforated as well. There's part of the alveolar crest, but it's definitely perforated. And it's very impressive, I mean, to say the least, right? Just look at the amount of resorption that has occurred. So it's best visualized in the axial and the sagittal view. Well, coronal view is still helpful as well. I think what's fairly clear here is that, at least from radiographic perspective, this resorption does extend into the canal or pulpal space rather than this enlarging from the pulpal space. So I would say that this is an example of external resorption. Or you can say cervical resorption as well, as it may have started from the cervical region and extended inferiorly. Now let's take a look at the adjacent tooth, number 2016. I think what we also from periapical radiograph was relatively well-defined radiolucency at the apex. But what was surprising to me was that right here. Let me rotate that so that we can capture that bone loss. Here, there's a radiolucency that's on the side of the root. Look at the sagittal view. And look here, coronal as well. Definitely from the first radiograph, we could not visualize this very well. And on the second PA, I think it was a little more noticeable. But again, if you only had a single periapical radiograph, you could have totally missed that. But with three-dimensional imaging, it's very clear that there are two separate radiolucencies. Another thing that you may have noticed is that our student were actually successfully found two canals. And let's study the morphology of the canal. So if you look at the sagittal view, let me kind of move in and out of sagittal view. I hope it's all clear to you that there's a bifurcation of the canal, or we can say two canals, and that appears to merge in the apical third. And it's a little more difficult to tell, but I think it exits as a two separate canals once again. One here and one perhaps exiting something like this. So it has a relatively complex pulpal morphology. So let's head back to our PA again and see how the gutta perches appear. Yep, right? So it's a two separate canal and they kind of merge here and then they come out separately into separate foramen. Anyway, I hope this is a good video showing you, demonstrating the differences or limitations of 2D image in comparison to 3D. Thank you very much for your attention. I'll see you next time. Take care.